Thank you very much, Salvador. It is my pleasure now to introduce my colleague and good friend, Susan Taylor. Susan is truly a leader in dermatology in the United States. She is currently the president of the American Academy of Dermatology. I've known and worked with Susan for many, many years. She is a leader and a pioneer in dermatology, especially in skin of color. And she is going to speak on personalized photoprotection for skin of color patients. Susan.
Thank you very much, Henry, and thank you for the invitation to this Congress. I have a few disclosures related to this particular talk, and they're related to the makers of various sunscreens. Now, although ultraviolet light composes only about 5% of the electromagnetic spectrum, of which 95% is UVA and only 5% is UVB, we find, particularly for our skin of color patients, what we have learned recently about the role of visible light and the skin, and much of that data has come from Dr. Lim's lab, it is very important when we advise our patients of color for photoprotection. Why is that? Well, we know that melanogenesis is activated by many factors, and these include medications, genetic factors, but most importantly, ultraviolet and visible light radiation. What happens is that we have tyrosine that's converted to L-DOPA, dopaquinone, and then on to melanin. And melanin is then transported into the surrounding keratinocytes. We know that melanin is the reason that many of our skin of color patients and all patients experience dyschromias. These include post-inflammatory hyperpigmentation and melasma. And these are a particular problem for our individuals with skin of color. If we look across the electromagnetic radiation spectrum, we know that UVA causes immediate as well as persistent pigment darkening, and this is more so in darker skinned individuals. Ultraviolet B, of course, leads to skin darkening, first erythema, of course, but then delayed hyperpigmentation. And then visible light. Visible light increases skin darkening in our patients with darker skin tones. In addition, we have the chronic effects that both UVA and UVB and visible light have on all skin types. In the United States, in regard to our sunscreen filters, we are very limited. We only have 12 organic filters and 2 inorganic filters, and they are very important for all of our patients. In regard to our organic filters, also called chemical filters, they are aromatic compounds. They're conjugated with carboxyl groups. They absorb high energy ultraviolet radiation, and then they convert it to low energy states that are then released. Our organic filters provide protection against ultraviolet B and shorter wavelength UVA2. They do not, however, provide protection against longer wavelength UVA1, nor do they provide protection in general against visible light. This is in contrast with our inorganic filters. They are also termed mineral or physical filters. They consist primarily of zinc oxide and titanium oxides, so they are metal oxides that come in various particle sizes. Both zinc and titanium can reflect as well as absorb both ultraviolet radiation as well as visible light. But the larger particles have a very chalky appearance, which is not very aesthetically pleasing. So most manufacturers decrease the size of those particles. And what happens is you then lose the ability to absorb UVA, and it shifts the effectiveness further to ultraviolet B. A little bit about visible light. Visible light, as I said earlier, makes up about 50% of the electromagnetic spectrum. And visible light results in increased release of reactive oxygen species. This is highest after exposure to blue light, and we term that high energy visible light, which has the greatest effect on individuals with darker skin types, Fitzpatrick skin types 4, 5, and 6, and some with Fitzpatrick skin type 3. What happens is that the reactive oxygen species activate opsin-3. That initiates a cascade of reactions that increase tyrosinase and dopachrome tautomerase. And that complex of tyrosinase and dopachrome tautomerase, that results ultimately in the production of melanin and hyperpigmentation in those skin of color patients. So here is an example of what happens to skin types 3 and 4 when they are irradiated with visible light, 450 nanometers. And this is, of course, our blue-violet high-energy visible light. And you can see after 24 hours, there's some erythema, but definitely hyperpigmentation. Note that the hyperpigmentation continues at day 7, after 14 days, and after 21 days. So that one irradiation with high-energy visible light in the blue range causes long-lasting pigmentation in darker skin types. This is in contrast to UVB. UVB, your skin irradiated, and after 24 hours, you can see the white circle, a little bit of erythema. 7 days, 14 days after UVB, no hyperpigmentation. This is in contrast to blue light. You see that with the red circle, whereas after 14 days, we have that long-term hyperpigmentation that represents damage to the skin from high-energy visible light, but also UVA1. So how can we protect our skin of color patients from the dyschromias that occur with the visible light and UVA1? Well, blends of iron oxide and non-micronized pigmentary titanium dioxide significantly reduces visible light transmission, and it can do so up to 90%. Now, the most effective visible light sunscreens, as we now know, contain iron oxide. We prefer a concentration of 3% or higher, but for most sunscreens, iron oxide is listed as an inactive ingredient without the exact concentration. We know that iron oxide comes in various oxidation states that confer different colors, yellow, red, and black. And when you blend those colors together, it creates a tinted sunscreen of various skin tones. For our darker skin patients, that of course not only blocks visible light or affects the reactive oxygen species generated by visible light, but also you can suggest to your patients that they use the tinted sunscreen as almost a camouflaging agent under their foundation or powder if they so use it. So we know that here's a study that clearly demonstrates the fact that iron oxide blocks the visible light and UVA1. Product A has no iron oxide. And you can see after irradiation, after day 1, day 4, day 14, we see that hyperpigmentation. Products B and C both contain various concentrations of iron oxide. And we do not see that long-lasting pigmentation, which indicates that the iron oxide does indeed block the whole mechanism of melanogenesis that leads to melanin production. Now, here's a very nice study of almost 70 subjects with melasma. All of these patients were treated with 4% hydroquinone for a 12-week period of time. The only difference was one group received sunscreen with protection against visible light as well as ultraviolet light. And in that group, the sunscreen contained iron oxide. The other group used sunscreen along with their 4% hydroquinone, but that sunscreen only conferred ultraviolet light protection. And we can see the results, i.e. the improvement in the melasma area severity score, a MASI score, was better in those individuals who used photoprotection from UV light as well as visible light. There are other mechanisms to protect the skin from visible light. A certain blend of antioxidants has been demonstrated, again, to result in a reduction in the UVA1 visible light-induced pigmentation. This particular study looked at a blend of antioxidants that contained vitamin E, vitamin C, the antioxidant lycocalcone and glycerotinic acid, as well as DESM. And what this particular study showed, that product C on the end did confer a reduction in the pigmentation induced by visible light and UVA1 that was similar to product B, which was a tinted sunscreen. So this is just another mechanism to protect our patients from visible light. Now, when we talk about personalized photoprotection in the United States, less than half of U.S. dermatologists report that they give patients some type of recommendations in regard to sunscreen use. And it's very important that we discuss with our patients photoprotection options. And that should be based upon the patient's Fitzpatrick skin type susceptibility, their risk of burning, their underlying cutaneous disease. So for example, I have patients who have hypertension, who have diabetes. They're on medications, oral medications, that make them more sensitive to the sun. We should also base our personalized recommendations for our patients on aesthetic considerations, their personal preferences. Also lifestyle, how much exposure do they have? There's some people who stay in the house during the day and other people who are working outside, like postal delivery men and women. And we of course have to consider the geography. It's also important when we have these discussions with our patients on personalized photoprotection that we do it in a culturally competent way with joint decision making. So for all of our patients, we want to present a comprehensive plan, not only sunscreen, although it does have increased importance, but we want them to seek shade. We want them to avoid midday sun. We want them to use protective clothing as well as accessories. For our skin of color patients, as well as any patient who experiences dyschromia, in addition to recommending a broad spectrum photostable sunscreen, that we want to recommend one that is tinted or that has the blend of antioxidants. For our skin of color patients, there are certain tips we want to give. Number one, many of our skin of color patients, particularly those of African descent, particularly those of indigenous origin or of Hispanic descent, many feel that they don't need sunscreen. Particularly my African American patients. So it's important to explain why indeed sunscreen is necessary. Some of these patients will sustain sunburns. Some of them are on some of those photosensitizing medications. Many, however, experience dyschromias, post-inflammatory hyperpigmentation, as well as melasma. So explaining the link between photoprotection and those dyschromias is very important because patients don't tend to understand it. Also, it's important to explain that the patient tries various different types of sunscreen because the aesthetics are different. Some do leave a white cast, others do not. Some match more closely with the patient's skin type, some do not. And when they come back, ask them how they made out, and then you can help them make adjustments. Also for our skin of color patients, let us not forget the importance of heat in generating melanin and for melanogenesis. So for those skin of color patients, we also have a discussion in addition to photoprotection with sunscreen, also about the importance of cooling and heat protection. Asian sunscreens have become very, very popular in the United States. You may have heard of K-beauty, Korean beauty. And when we take a look at those sunscreens, we see they have a variety of filters, very good protection from ultraviolet A light. And also, I think the key here is that all of them are completely transparent And they have other properties. They have hydrating properties. They have anti-aging properties. And that has made them very, very popular, particularly in the United States. They don't have a greasy feel. They're fast absorbing. But many of the filters in the K-Beauty sunscreens are not approved by the US FDA. The other problem we have found is that our patients get them over the internet, and often there are many counterfeit products. So we don't recommend in the US these particular sunscreens for our patients. Finally, don't forget the cost of sunscreens. The cost can be prohibitive for many of our skin of color patients. So it's important to advise seeking the shade, the long sleeve shirts and pants and hats, and then the areas of the body that are indeed exposed and you apply the sunscreens, it becomes less costly. We see that in the US, those with darker skin tones spend much more money on sunscreens. And there's an interesting study that demonstrated that the more expensive the sunscreen, the less that the patients do apply. Here are some general recommendations from the African population. Very, very similar to what I said. So in conclusion, when we look at personalized photoprotection, there are differences depending upon the Fitzpatrick skin phototype. Of course, for all of our patients, we want to capture and protect against UVB and UVA, but for our darker skin tone patients, we want to particularly make sure that they are mindful to protect their skin with tinted sunscreens or those that contain a variety of antioxidants to really address the high energy visible light. And with that, I thank you.
Susan, yes. Before going to the next presentation, I would like to give you our that we are going to make you an honorary member of our Society of Dermatology, which is a real honor for us.